Everybody more or less hypoglycemic, sleepy. So I'll start with a joke. Two engineers were talking about their drilling tunnels in the mountains for railroads. One boasted that we started from two ends and we ended up only in 1 centimeter difference when we collided. The other one told that yes, we started and we never met each other and we went through. So where is the accuracy? Man, with your accuracy you got one tunnel, with our less accuracy you got two tunnels. So we are better than you. Friends, we will have the search for accuracy in having two tunnels here. The convergence issues when we go for ligamentous injuries around the knee. So you had come across that tunnel in IOA-CON. Here, if you can see the end of the tunnel, then it's I cannot see the end of the tunnel, then it's a socket. And maybe you are standing inside the tunnel and happy, smiling like Ananda and Swarnendu, and suddenly this thing comes up from the side, a guide wire. Not only that, comes up a reamer. So what will happen to Swarnendu and Ananda? They'll be destroyed. So you try to avoid those distractions. That is graft damage. So this is essentially the damage to the graft which is already there. You have seen an example just a few minutes back that it was dangerously close to the ACL. The tunnel which was being made for the anchor, tenolock anchor, was very dangerously close to the ACL tunnel. Then there can be fixation impairment. Suppose you are nicely fitting this endo button and suddenly there is another tunnel around this tunnel and then there can be a disaster. Collapse. If the tunnels are very close to each other, not much bone breach, and considering that many people are vitamin D deficient, even young people, then there can be, when you tighten the screws, there can be collapse of the tunnel. Okay? So there are set patterns, of course. Set patterns. In the medial femoral condyle, you have the PCL tunnel that is sacrosanct. You do not play with the positioning of the PCLs and ACLs. We change the directions of the other two ones. For superficial MCL, you have a figure of 40-40. 40 degree anterior and 40 degree towards the hip, cephalic. Proximal means cephalic. If you are going for a 0-0, then there is a possibility of violating the intercondylar notch. And if it's more than 40, then there is an oblique elliptical tunnel which is not good for, elliptical mouth of the tunnel which is not good for fixation. For POL, it's an IPL like T20 match, 20 degree anterior, 20 degree proximal, to avoid all those things. In the lateral femoral condyle, you have ACL tunnel which is sacrosanct. We can change the directions of the tunnels of the LCL and popliteus tendon towards 0 degree cephalad, that means very transverse, and then anterior direction, drop your hand to have the anterior direction of 40 degrees. For ALL, there are so many techniques, it is very difficult to go for one set piece movement, but for the commonest technique, your anterior should be 30 degrees and again proximal should be 30 degrees to not to violate the ACL tunnel. And if you are going for a LEAT, you have already seen a live example of LEAT. Okay, so modified lemur is preferable. If you go for Macintosh, then there is basically no chance of any tunnel convergence. In case of tibia, ACL, PCL tunnels are sacrosanct again. If you go for superficial medial collateral ligament in the tibial insertion, normally without any multi-ligament injury, normally we go for transverse orientation, but here it can cross the PCL tunnel. That's why you aim for about 30 degrees caudal, like here, and should be anterior to the fibula because you know the danger is there. And for POL, normally we aim at the Giardi's tubercle, we put our other finger to the Giardi's tubercle and direct that way. But here, because the PCL tunnel is there, to avoid that, we shift our aim 15 mm, approximately 15 mm medial to the Giardi's tubercle to avoid this PCL tunnel, and it is horizontal. We have deliberately left out, because of the time constraint, the pediatric cases where the physis is still there, concomitant meniscal root tunnels, concomitant osteotomies for those are for different level, and lastly the caveat is that the bone dimensions, those studies are on for European and the Caucasian people. Our people anthropologically are slightly different, so there are difference in the dimensions, and they also the study designs have to be taken into consideration, because some of them have done only 10 cases on cadaver or 15 cases on in vivo. So we have to have our own database, we have to have our own research in this respect to avoid those tunnel convergences. Thank you.